Everyone have a good break between the pinning ceremony to now? A relaxing weekend? Anyone majorly sunburnt? A few, yes. I narrowly escaped that. My normal pallor was protected most of the weekend, fortunately. So this is physiology. This is a new course for me that I'm teaching, so you guys get to be my guinea pigs for this semester, so that'll be fun. I am Adam Wood. I am, as you can tell by my credentials, a PharmD. That is not an agricultural degree. I am a pharmacist by trade. Yeah, that's bad. So I'm a pharmacist, so this is actually a really good example of how we can kind of get interdisciplinary kind of approaches introduced to you guys pretty early on. So it's nice that you guys don't only have PAs and physicians, we also can have kind of a pharmacist perspective on some of these things. And this is a really good class, I think, for me to teach because a lot of this is so kind of intrinsically intertwined with how medications work, right? And so you'll also see me on Thursday for pharmacodynamics, which will be kind of our introduction to pharmacy, the pharmacy world, and then we'll do Pharm 1 and Pharm 2 in the following semester. So that's kind of where you'll see me also do some research courses as well. So that's usually the main places you're going to see me at. You also notice I have a DABAT after my name, and that actually indicates that one of my main interests is in in clinical toxicology. So that actually means I'm a board certified clinical toxicologist. Basically anything from drug overdoses, envenomations, snake bites, spider bites, things like that. That's kind of my main thing that I enjoy doing. Primarily my background, I did a 2-year fellowship in that up at the Jacksonville Poison Center up in Jacksonville through Shands UF. So I spent a lot of time doing emergency medicine, did a lot of peds, doing toxicology thing, working with the Poison Center, and then after that I actually moved down here to Orlando to work at Nemours Children's Hospital. So has anyone seen that or been by there? Yeah, so it's a pretty nice hospital, fairly new. We opened back in October of 2012, so we're actually coming up on 5 years pretty soon here, which is nice. I was there probably about 2 or 3 years doing peds ED full-time. And then I kind of moved into more of an administrative role. I was teaching here as an adjunct, doing the pharm courses for a few years, and then finally decided to make the jump to do this full-time. So that's kind of my journey and where I've come to here. So that's kind of my main things is like pediatrics, emergency medicine, toxicology. Those are the 3 things that I claim to know the most about. Everything else I get some smatterings in here and there. But that's a good point to make, that I'm not an expert in everything. And I'm very fallible, so if you notice something I say and you're like, that doesn't sound right, like call me out. Like totally fine. I'm not going to be mad about that. It's a good learning opportunity for everyone to kind of come into that. And I certainly encourage frank discussion back and forth here. This is going to be really boring if I'm just yapping at you for 2 hours straight, or sometimes 4 hours, sometimes 6 hours, which I noticed on the schedule, which can be a little intimidating, both for you and me. But I ask a lot of questions. I try to get kind of feedback from you guys and kind of talk back and forth. So the more vocal you are, the better discussions we can have, the better I think you'll be able to learn. Because again, if there are no dumb questions. I'm not here to make anyone feel bad for not knowing something. But if you have an idea about something, just shout it out. Like it's no problem. Any questions, feel free to raise your hand. I'm not gonna. I can stop at any time to kind of field those. I have a tendency to talk pretty fast. So if you notice that I'm getting a little mumble mouth, like just raise your hand, tell me to slow down, or throw a shoe at me or something, whatever you need to do to slow me back down, and that would be good. So any questions to begin with before we start talking about the course in general? Okay, so anyway, this is physiology. Again, as I mentioned, this is my first time teaching. Be a good learning experience for both of us, trying to gauge how to really teach this stuff and communicate it appropriately. There are going to be 4 tests for this class. I think I updated the dates to the correct ones. You can see they're mostly on Fridays, one Wednesday test. Essentially, there's going to be about 12 hours of lecture for each test. So we'll do about 6 class periods, and then we'll have the test and kind of rinse and repeat for 4 tests. You need to have an average of a 75 in order to pass the course. So even if you bomb the first one, you can definitely come back on the subsequent test. As long as you hit that 75 average, you're good to go. Even a 74.8 has gotten people through some of these courses, so that is certainly totally fine. As far as test failures go, if you do fail a test, and this is kind of a general approach for any test you fail, you need to go to the course director along with your advisor. If you do fail an exam, we are able to go over questions that you may have missed with you, kind of on a one-on-one session. If you pass the test and you're like, oh, I wonder what I've Can you go back through and run over those questions that I missed? We can't do that if you pass it. But if you fail, we can certainly go through, kind of go question by question if you need to. And then there will be paperwork that both the course director and your advisor will sign, and then it goes to Dr. McClary as the academic director. And then if you do fail the course, which none of you guys will do, right? Everyone's going to pass. Not to scare you guys, but one of the second years, or incoming second years, just told me that during my first lecture, they actually went to the bathroom halfway through and had a panic attack, said they weren't going to pass PA school. And I was like, no. She's doing fine, though. She's still going into her second year, and she's out of all my classes. So she can survive. All of you can as well. So I have high hopes for you guys. But if you do fail the course, there will be a comprehensive remediation test that will occur. If you pass that, then you can still kind of continue on. So I don't foresee any of you guys needing to do that. But if that is needed, they'll be scheduled kind of on a one-on-one basis. Okay. Again, it's 3 credit hours. Again, 12 hours roughly of lecture time per section. Here are the rough chapters that we're going to be going over. The book that we're using is Guyton and Hall, Textbook of Medical Physiology. I put here how to get to it. Have you guys been to the Nova Library website? Get used to it. There's lots of good books on there, lots of good information that you can pull from. And I actually put a link up to this on the main course website. So if you click on that, you may have to log in, but it'll take you straight to the book. Otherwise, you can follow this this pathway where you go to databases, find the database clinical key, and then go to books, and then you'll find the actual textbook there under G. So you can find that. I actually think the book is really good. Has lots of good explanations on things. If there's something that I did not go into enough detail on, certainly you can go back through and kind of review that and get into a little bit more detail on that. The one for pharmacodynamics is like the pharmacy nerd Bible. You probably won't be consulting that one too often, but just in case, I'll show you how to get to that as well. So what are our objectives today? And how many of you have had physiology before? Everyone, fantastic. It's almost like it's a prereq or something. So you guys have probably had physiology sooner than when I had physiology, at least when I was back in college, right? So you guys may be able to teach me some stuff. Or if I say something wrong, for sure, like, call me out. I definitely do not mind that. But basically, we want to kind of pull this into the perspective of you guys being able to recognize and discuss kind of the principles of normal physiology. You guys will certainly go into the pathophysiology in subsequent courses, but this is to make sure everyone's kind of on the same baseline, everyone's on the same page, and kind of speak with the same kind of knowledge base. And then we'll kind of build on your clinical skills after this. We try to group this with anatomy pretty closely, so that way we're kind of going over the same systems roughly at the same time. There might be a little bit of variance there, but we try to schedule things out so it's pretty close. So we'll look at organ systems and how they kind of function within one another and how they influence one another. And I'll try to pull in some like actual clinical information or clinical perspective on a lot of this stuff, because that's how I know it. Like, you know, if we're talking about the endocrine system, like, you know, I see diabetes, I see, you know, thyroid dysfunction. I'll try to pull that in so that way at least give you guys some perspective, even though you won't have covered it in your CMS course yet. It'll at least give you something to kind of latch onto, and maybe something you'll see later on in your coursework. And again, having good mastery of this is going to be the fundamentals to having you be able to understand not only things like, you know, how, you know, the pathophysiology of hypertension works, but how do the medications that we're going to use work? You know, how do they work on these different receptors and different pathways in order to cause, you know, the therapeutic effect that you're looking for. So it's a good kind of background knowledge to have. So we're going to begin with our introduction and body function. So this is basically the way that the first section is going to go over, the first 6 lectures or so. We're going to do introduction, kind of normal body function, kind of a real brief overview of that. Then we'll start to talk a little bit about chemical composition of the body. So who's a chemistry nerd? Anyone? Okay, we'll get to talk briefly about that. Very, very surface level kind of stuff there, but just the basics in order to make sure we're all on the same page. Then we'll talk about cell structure and genetic control. We'll talk about enzymes and how energy is produced within the body. Anyone know what the powerhouse of the cell is? Mitochondria. It's like the one thing everyone knows about physiology. They've never taken a class. The powerhouse of the cell. So we'll talk about that there. And then we'll also talk about cells and how they interact with the extracellular environment. We'll talk about things like action potentials and how they maintain you know, electrochemical gradients, all kinds of fun stuff like that. Following that, we'll talk about the endocrine system, and then we'll go over the sensories, basically, you know, sensory functions, talk about touch, talk about, you know, taste, hearing, all of that good stuff. Cover those in the final 2 lectures. I like to have a review typically before the test, so in some cases I may actually record an extra video to wrap up any material, and then we'll do like an in-class review. People normally like that. Have you guys used Kahoot before? Kahoot? It's an online service where basically you can generate tests and quizzes online, and everyone in the classroom can actually log in with their phone or their laptop, and we can have kind of interactive sessions where everyone gets to kind of contribute, get to see where like deficiencies are in people's knowledge, get to it's kind of competitive too, so it's nice to kind of set you guys against one another, Hunger Games style a little bit. Just kidding. Yeah, no, there's no actual prizes, but you at least get to feel good about yourself afterwards. The objectives after section 1, you should be able to discuss kind of normal organization and function of a cell, and then we'll also talk about this membrane physiology and other action potential. So there'll be other big things we're going to be covering. So first off, we'll talk about body function. We'll get into more types of tissues, but we're going to start with kind of the highest level and then kind of work our way down to kind of more complex tissues and organs and things like that. Back into kind of the medical context to try to show you guys like how this stuff actually comes about in actual clinical medicine, how we kind of encounter this. The first thing, and probably one of the more important things we'll cover, is going to be homeostasis. So what is homeostasis? Who can describe it?
It's like the range of balance.
Okay, so it's a range of normal. We want to stay normal, right? Everyone would like to be normal. No one wants to be abnormal. In a lot of cases, if you become abnormal, that's where disease can occur, right? So, for instance, if I were to turn down the temperature in the room to make it very cold, say 60 degrees in here, what would you guys do? Be happy. You may be happy. What else would you do?
Shiver.
You might shiver. That's one way you can do it. What's another thing you could do that your body's not even doing? You're just kind of put a jacket on. Yeah. So you could like maybe put a jacket on. If I were to turn it up to 98 degrees, what would happen? Sweating. You could also take your jacket off. Absolutely. So that is kind of natural homeostasis, right? You want to stay within a normal range. Try to keep your body kind of in the norm, so to speak. And so normal physiologic processes you'll see that sometimes the ranges can be pretty wide on what we consider to be normal. Sometimes it's actually very, very narrow in regards to the range that your body wants to stay within. So say, for instance, like hydrogen ions. If we're controlling the pH of the body or the serum, may vary hydrogen ions by just 5 nanomoles per liter. So very narrow tolerance that you have there. Serum sodium concentrations. Normal serum sodium is like between 135 to 145 milliequivalents per liter. If you go higher than that, you're going to see disease pop up. You're going to see neurologic problems, all kinds of issues. If you go well below that, we have cases of hyponatremia where patients come in with a sodium of 119. Even that that minor deviation from normal is enough to cause seizures and cause all kinds of other issues to occur. So it's important that we stay within this normal range, and we're going to look to see how the body maintains that in a lot of cases. Again, the body can only do so much, and so in a lot of cases you're going to see that when we overwhelm these homeostatic processes, that's when disease occurs. So say, for instance, what's one of the main hormones that controls your blood sugar? Insulin. Yeah, insulin's a big one that helps control blood sugar. If I just continue to eat, say, sweets constantly, and I can only pump out so much insulin, right? Eventually I'm going to overcome that and give my body too much sugar, and then you're going to see disorder there. And what do you call it when you have too much sugar in the blood? Hyperglycemia. What's the kind of the disease state that develops eventually? Diabetes, right? In that case, would that be type 1 or type 2 diabetes? Yeah, that'd actually be type 2. So if I overwhelm my body's ability to produce insulin just because I eat too much crap, you're going to develop type 2 diabetes, right? So again, the body can only do so much. Disease occurs when you start to go outside of that. And you're going to see that homeostasis is normally done by negative feedback loops. So can anyone describe a negative feedback loop?
Like if something is high out of spec, then your body will make it low out of spec, or come back down, the opposite of whatever it was.
Exactly. Yeah, your body's trying to do the opposite of whatever the out of range thing is. So for instance, if I drop the temperature down in the room, you guys are going to put a jacket on. If I up the temperature, you guys are going to take the jacket off, right? So those are kind of negative feedback loops, and so we'll see how those kind of get integrated in a few different examples here. Any questions, feel free to raise your hand. So again, you have a lot of different types of sensors within the body that help to detect these change, right? So you'll have these kind of initial receptors that are detecting some sort of aberration that's occurring there. It's going to send it up to an integrating center within, usually in the brain. Usually the hypothalamus is one of the big places you're going to see that these get integrated. And then it's going to send down an effector signal, right? So say, for instance, if there are baroreceptors, what do you think baroreceptors detect? Pressure. Yeah, absolutely. So pressure. So for instance, if I have too high a blood pressure, that's going to get sent up to the hypothalamus, and my body's going to respond by doing what, do you think? How could I lower blood pressure? Dilate blood vessels, right? Absolutely. So that could be one of the main things that I can do to help regulate that blood pressure, right? So there's an effector, there's some sort of sensor, there's an integrating center, and then there's going to be some sort of effector that occurs after that to try to get back to that normal set point. And again, think about it that you can have these normal ranges. They can actually change over time, because you're going to find that if you're constantly hammering those baroreceptors, you're constantly having high blood pressure, eventually the baroreceptor is going to say, well, this is just normal now, right? And then now you have hypertension, right? So you can see that these effectors or these sensors can change over time based on how you treat them, right? So if you're having high blood pressure, if you have high blood sugar, that may just be the norm for those patients after a period of time. And that can take time to where you can see that adaptation that occurs with the different types of receptors. So again, if you're looking here, let me get the laser pointer. So, for instance, if you were to have, say, like a normal range, so say we're looking at like temperature or something like that, if you were to have an increase in that value over time, you're going to see that the sensor detects that. It says, hey, we're too hot here. You're going to have an integrated center, usually up in the hypothalamus. Is going to go back down to the effector, whatever happens to be. Say you start to sweat, right? Sweat is a good way to help cool the body down. You're going to bring that temperature back down to normal, and then now that sensor is back in a normal range. And it says, hey, everything's great. We're back in homeostasis. Okay. The opposite can also occur here as well. Very similar. If you were to get too cold, you're going to start to shiver, do things to try to get your body temperature back up. You're back up to normal, and then everything's copacetic at that point. Okay. So this is a very normal process that occurs with almost everything in the body. Another really good example of this would be a lot of endocrine functions. So you guys are familiar with the thyroid gland. What is the thyroid gland when it produces thyroxine or thyroid hormone? What do you think that does for us? Anyone know? Increase in metabolism. Anything else? It can help like regulate temperature. It can help to regulate energy levels, lots of things like that. So you'll see when we get to the endocrine section, the thyroid gland is very, very important. And when you have aberrations in that, and a lot of people do have aberrations and maybe don't even know, we'll see how we can affect that. And certainly when we get to pharmacology and things, we'll see how we can replace that. But this is a really good example of a negative feedback loop. Essentially what happens when you have this this hypothalamus thyroid axis, right? So you're going to see the axis with different points along the pathway. You have the hypothalamus up in the brain. It's going to be releasing this thyrotropin releasing hormone. Okay, so you can see that usually abbreviated as TRH. If you ever see an abbreviation I don't mention, just go ahead and make me clarify that. But thyrotropin releasing hormone, that's going to have a positive effect here on the anterior pituitary. That's then going to release another hormone called thyrotropin. That thyrotropin is going to then go down to the thyroid gland and start to activate it. It's going to say, hey, we need to get more T3 and T4, right? So those are going to be our main thyroid hormones we're going to be releasing. We'll go into more detail on that later. Anyway, and so thyroxine, that's another name for T3. I'm sorry, T4. So anyway, so thyroxine gets released here, and then once your body detects you have enough thyroxine circulating in the bloodstream, it's going to cause a negative feedback loop. And not only does it cause it here in the anterior pituitary to shut off release of thyrotropin, it's also going to hit back up here in the hypothalamus as well to try to shut off thyrotropin releasing hormone. So you can see that this negative feedback loops can affect separate sites in order to try to shut down that pathway. Okay. Now on the other hand, say for instance I did not have enough T3 or T4, what do you think this pathway is going to do? It's going to stimulate the hypothalamus. It's going to stimulate the anterior pituitary to try to stimulate more of that thyroid hormone production, right? So if I take away the brakes off the system, it's going to help to stimulate it and try to get back to a normal range. So as an example of this, one of the things that you can see for a patient who say is, and so one of the, what metal is really, really important for producing thyroid hormone? Yeah, iodine is super, super important. So one of the things you can actually see, and this can cause disease, is if you were to have the hypothalamus says, hey, we don't have enough thyroxine around, right? We need more T4. You're going to start to release that thyrotropin releasing hormone, which is going to affect that anterior pituitary gland, right? That's going to release more thyroid stimulating hormone, that TSH. That's actually going to be one of the things that we're going to measure when you're trying to evaluate a patient for either hyper or hypo thyroid. And that should stimulate the thyroid to make new thyroxine. Well, if you don't have enough of that substrate, if you don't have enough iodine in your normal diet, which here in the U.S. we normally have iodine being fortified into a lot of our foods, we really don't have to worry about it. But in a lot of developing countries, they may not have that, and so this can be much more of a problem. So even though the thyroid gland is being activated, by this TSH. It doesn't have enough substrate around in order to actually produce the hormone. So then what happens is you have this hypertrophy of the gland that occurs because it never can activate that negative feedback loop, right? Because that T4 is never made, it never feeds back and shuts off the anterior pituitary and the hypothalamus. So what you end up getting is what we call a goiter, right? So it's just trying to help stimulate that tissue, produce thyroxine, but the thyroxine is never being made, right? So this is why if you Google goiters, you can see this, especially in a lot of patients in developing countries have just kind of massive thyroids that are being developed because they had that constant TSH amount in the bloodstream trying to help generate that T4, but nothing's happening, right? Everyone with me so far? Fantastic. This is all review for you guys, right? Everyone's pretty much familiar with it. Okay, I'm going to try to like make it more kind of clinically based. But another good example, as we've already mentioned, is temperature is going to be another thing here where we can see that we can help control our temperature, mainly if it drops too low. We can do things like shiver, try to activate those muscle tissue in order to generate heat. If the temperature goes too high, we can start to sweat and things like that to help keep things at a normal set point. Can you think of anything that would cause you to go outside of these ranges to where your body maybe could not keep up? Fever, yeah, it could be a decent one. So again, you can have fevers that are too high that can actually, even though you're sweating a ton, you can't really work off that temperature, and that can lead to brain damage. If the temperature were to get too high. Any other things you can think of? Heat stroke, absolutely. So who was outside this past weekend? I nearly had a heat stroke myself. We kind of a funny story. So we were trying to do. It was my daughter's 1-year birthday, so we were actually having a birthday party, and a lot of her little cousins and stuff were around. So we were trying to do a photo shoot outside. And let me tell you what, there was like 7 hot babies out there, and it was not good, not good. They had a poor ability to help regulate their temperature, even worse than the adults did. And we were about to stroke out there. So. Anyway, what are some other situations you may run into, either hyper or hypothermia that your body can't really counteract? Yeah, cold water is a good one. Yeah, so if you were to have like a drowning or something like that, we actually had a good case of that where, in Florida, drownings are an unfortunate, just common thing, especially with kids. So we have a lot of kids that come in that are near drownings. Basically, they have very profound neurologic deficits afterward just because they have hypoxia to the brain. Right, brain's not getting enough oxygen, things start to go bad. But we actually had one child who fell into a retention pond who actually was cold enough to actually help to preserve some of that brain function. So we actually ended up doing very well. So you can see where temperature can kind of help us in a lot of cases. You'll find that especially like in patients with cardiac arrest, sometimes we'll do therapeutic hypothermia. We're trying to drop their temperature down really low to help preserve that tissue function, try to help preserve them a little bit longer while the body kind of helps fix itself. In those cases, we actually have those patients, we said you get cold, what does your body want to do to help regulate that? You want to shiver. We actually want to keep those patients from shivering because if they shiver too much, we can't keep their temperature down. So we can actually give them things like paralytics, which actually will shut down all that muscle activity and help keep them at a low temperature. So you can see where now we have medications that can help to block that effect to help keep that temperature in the range we want it to, right? So lots of different examples where we can use this to our benefit. In my world in toxicology, we see a lot of drugs that can help raise the body temperature to unsafe levels. So things like amphetamines, cocaine, a lot of stimulants can actually do that to where you can have very, very high temperatures and basically the patient just fries their brain and they're no good after that, right? So lots of bad things can occur if you get out of these ranges, but sometimes it can be therapeutic. So again, usually the negative feedback loops are working through these antagonistic effects. So usually you're going to have opposing effectors, right? So if you're too hot, you're going to try to do things that help cool your body down. It's an antagonistic effect. You're going to see that when we talk about drugs, especially, that you're going to run into a lot of antagonists that will help kind of achieve these similar type of functions. And so the ability to maintain ourselves within that normal range is called that dynamic constancy. And again, that can be shifting because if you were to plot out your temperature, say you took your temperature every single, say every 15 minutes for a 24-hour period, do you think it would be the same exact temperature every single point during the day? No, there's going to be some variation there, right? So there's going to be either circadian rhythms that can be affecting that. There can be other variances if you go outside, if you go inside. Things can be affecting that, but normally you're going to stay with that normal range. Other good examples of this we'll talk about more in detail include things like blood glucose levels and also blood pH are another good example. We're trying to maintain ourselves within a pretty strict range. There's going to be some variation there, but we can normally keep it in most cases. Again, there's going to be some ranges there It may dip a little low, may go a little high. And again, over time, if you were to constantly ride some of these values too high or too low, you're going to see adaptation occur over time to where those receptors are going to be saying, okay, this is my new set point. Now this is normal, right? So they kind of a new normal they're going to be adapting to. So hypertension is a really good example of that, where if you're constantly having high blood pressure, your baroreceptors just say, well, this is normal now, this is my life, and then that's the new blood pressure. And so hypertension is just their normal, and so we're giving them medications to help kind of kind of put that back in check. So glucose homeostasis is a really good example of this, and lots of different effectors that can go into this. So we mentioned insulin is really good because it does what to blood sugar? Makes it go down, right? So where does that glucose go to? It goes into the cells, right? Because if you think about insulin, it's really an anabolic steroid, if you think about it. So helps to cause tissue growth, helps to drive nutrients and glucose into the cells to help them have good energy stores and things like that. On the counter side of that, what helps to raise glucose? Yep, glucagon. That's actually a common medication we'll give to patients who are hypoglycemic. And what does glucagon do?
Makes fat breakdown. Fat breakdown.
It can help the fat to break down, but more immediate. That takes time. That's actually kind of a slow process. What else can it do? Yeah, break down glycogen. Yeah, so you have glycogen stores, especially within the liver, and you have a process called gluconeogenesis. And so, if you're in a state where you have low blood sugar, your body's going to want to secrete glucagon from the pancreas, and that's going to have a positive effect on the liver to help generate new glucose. So gluconeogenesis breaks down glycogen to get that. That will then raise blood sugar levels up to hopefully a normal range. And then, what do you think that does to glucagon secretion? Should negative feedback, and then you should have less glucagon secretion, right? On the flip side of that, if you were to have increased blood sugar, your insulin levels are going to do what?
Go up.
Yeah, they're going to go up. Yeah, so insulin levels are going to go up in response to the high glucose. It's going to help to drive it back down, and then once you get back into a normal range, insulin secretion does what? Goes back down, right? Absolutely. So again, it's very much common sense kind of thing where you see how these systems kind of work, right? So, and again, this is all going to be within only certain ranges. So at a certain point, you're going to be able to exhaust the ability for you to maintain these normal blood sugars, either due to the fact that, like, if you think about a type 1 diabetic, right? Well, what's the problem with a type 1 diabetic? Yeah, they cannot secrete insulin, right? Because their beta cells have been basically wiped out for whatever reason, and so they cannot secrete insulin. So then they have nothing there to drop their blood sugar back down, and that's where they can develop. Does anyone know what they can go into if they have too high blood sugar for too long? Yeah, diabetic ketoacidosis, or DKA, right? So they don't have that insulin to cause that negative feedback loop, and so their blood sugar stays too high for too long. Their body can't utilize that glucose, and then it goes into this ketoacidosis. You guys will go into much more detail on that later, but just as an example of what can happen when these systems go wrong, right? And again, this is basically a seesaw kind of thing where you're trying to maintain a normal blood sugar, say if you want to stay between 80 and 120. Over time, though, especially with type 2 diabetics, if you just chronically eat bad food and you have kind of a bad lifestyle, you're going to see those normal glucose levels kind of just creep up over time to where, normally 80 to 120 might be normal for them, say, at age 16. By the time they're 60, say, like, 180 might be normal for them, just even at a fasting level. It depends on, how much they've worn out the pancreas. Maybe they're not secreting as much insulin. You also see what we call insulin resistance that can develop, right? So if you're hitting receptors too often, we'll talk about this downregulation process that occurs a little bit later on, but that can help to blunt those homeostatic processes and inhibit that negative feedback. I think it's just an example. The seesaw can go too far one way, and then you have someone on the ground, right? So just remember that this is all within certain ranges. Eventually, things can get overwhelmed, and you can have an epic fail. Okay, so there are cases of positive feedback loops, right? So this is a case where we want to help, we see a process is starting, we want to help push that in the right direction, keep that going even more. So I have kind of an amplification of these processes in order to get whatever physiologic effect we want done, right? So basically, a good example of this would be a blood clot, right? So if your body detects that there's endothelial damage, so you cut yourself, not that I'm trying to cut my wrist, but just for instance, if you cut yourself, you would have blood leaking out of the endothelial tissue. That's going to be releasing all sorts of different mediators that will stimulate the blood clotting process, and they will see how that can amplify itself through the different factors. Another good example we'll look at is going to be uterine contractions during birth, and then we'll also look at luteinizing hormone during ovulation. Here is an example of, say, a blood clot that's occurred, or going to be occurring. So here, notice you have this endothelial damage. You have a broken blood vessel, right? You're going to have these red blood cells leaking out, you have platelets and things like that. This is going to kick off a process. And again, have you guys ever covered the clotting cascade? You will in much more detail. I'm not going to have you memorize it here, but just for illustrative purposes, you'll see how this kind of works. There's a couple different pathways that can occur, but notice here, for instance, you have activation of factor 12A, right? This will cause activation of factor 11A, and this will cause activation of factor 9A. You see how it kind of goes down. The nice thing here is it's kind of hard to see on this green, or on the green on the white background, but you can notice here how things like thrombin, factor 2A, that can actually go back, feedback, and actually help to activate factor 11A again, right? So by having this cascade occur, it can go back and activate itself to cause more clotting to occur, right? So it's a positive feedback loop where activation leads to further activation. And that's a good thing, right? Because you want this clot to occur and stop the bleeding from happening. Now, what would happen if we had this going on unchecked and just continued to feedback, positive feedback unchecked? Yeah, you'd have a thrombus, right? So, and you don't necessarily want a thrombus where you don't want to clot all over the body, right? That can lead to big problems like pulmonary embolism. That can lead to stroke, all kinds of different problems. So it needs to be tightly regulated within certain bounds, and so that's where we have anticoagulant type products as well. So we'll have things like protein C or protein S that can actually help to regulate that and make sure you have, heparin is a common drug that we give in the hospital, but is also a natural product your body makes, can help to regulate this and make sure that you don't have too much clotting. You have just enough to help block off that the bleeding, and then stop that, and then you're done, right? So it's important these do not go continually unchecked. Another good example of this would be during the birth process. You're going to see that having the baby getting ready to kind of descend and make its appearance will put pressure on that cervix, which is then going to help stimulate a release of oxytocin. Have you guys ever heard of that hormone? What do they kind of describe it as? Yeah, the bonding, the love hormone, right? So that's one of the things that is really secreted in high amounts during the birth process, because that helps to ripen the cervix more, helps to get things ready for the baby to make its appearance. This is often something we'll give as a drip to the mother during birth in order to help kind of stimulate that process as well. Maybe they're not making enough oxytocin, we can give them extra to help stimulate that birth process, right? As a teacher, I don't want to abuse my power, but the one way I will abuse it is to show pictures of my daughter. So here was her after her mom got oxytocin. So this is day 1 of her being born, and then here was her at 1 year. So she's pretty cute. So anyway, so this is what we did. We actually had to give my wife an oxytocin drip in order to help kind of stimulate the process. It's kind of interesting because what do pregnant women often get during childbirth? Yeah, they get an epidural, right? And that helps to do what? It helps with the pain, right? Because again, it's a lot of pressure, it's a lot of pain that can occur during the birth process. And so what's interesting is that because that feeling is somewhat numbed, we actually give local anesthetics along with an opioid analgesic to help deal with that pain. The mother doesn't really feel that same kind of urge to get that baby out, right? So it can sometimes lead to extended labor times. So my wife was in labor probably 16 hours, right? And so the doctor was like, well, if you didn't have that epidural, and you would have pushed that thing out like hours ago, right? Because you're just like, I want this thing out now, right? But because she wasn't really experiencing that as much pain, the oxytocin helps to kind of supplement that to help lead to a little bit faster process, right? So who knows how long the labor might have gone on if she didn't have the oxytocin drip, but that was one thing that we can use to help. And an example of a positive feedback loop. Okay, luteinizing hormone is also another really important hormone to help stimulate ovulation. So you can see here, ovulation is basically going to be this development of a viable ova that can be implanted during ovulation. And so you can see here how you end up having these luteinizing hormone surges that occur here. It's a positive feedback loop to help make sure everything kind of develops normally. You have a good ova that's ready to go for implantation, right, during the ovulation period. Again, I don't claim to know how women work, so when we talk about women's health stuff, you guys might need to help me out a little bit. Okay, I'm surprised I'm still married at this point. Just kidding. Okay, so how do we determine if the body's within the normal range? Like, what can we do to actually detect to see, like, okay, is this person normal or are they abnormal in their ranges? And so it's really important to have a good idea of what normal lab values can be for your patients. And so this helps you to find out if they have disease or not, right? So if you're measuring their blood sugar and it comes back 600, as we did, we actually had, I work in the ER on Friday nights, and so we had actually 2 patients who came in, 2 children, who came in for weight loss, polyuria, kind of classic signs of diabetes, came in, got their blood sugar checked, and it read 600, right? 600 is a very high blood sugar. And so that was how we diagnosed them as having type 1 diabetes, right? That was the first sign that actually came about, and that was a good indicator of, yes, they probably have diabetes. And so we can also look at things like assessing the drug effect. So if we were to give that patient, what kind of drug can we give them to help regulate their blood sugar? Give them insulin, right? So we have exogenous insulin we can give these patients. That would help drive their blood sugar down. We monitor that to make sure they're kind of getting back and having the appropriate effects. We had to make sure we didn't give them too much insulin because that would cause hypoglycemia. Yeah, exactly. Yeah. So again, medicine's pretty intuitive in a lot of cases. So if it sounds like it's too easy, it probably isn't. Just shout it out. So again, we had to monitor them, their blood sugar every hour for 2 hours to make sure that after we gave them insulin, it did not go hypoglycemic. And again, you would have other signs and symptoms that go along with that, but lab values can help us with that. We could look at other treatments as well and see how they're going along with these lab values. We can measure lots of different things. Here's some examples. I'm not going to have you memorize this entire table. That will be that will come with practice, and that will come with seeing it over and over again. There are certain lab values, especially when you get out there and you're working in the clinical world, you're just going to know, right? Like I know what a normal serum sodium is. I can look at a Chem 7, which is a basic metabolic panel that will tell you certain electrolytes within the body. I can, the more common ones, and I can tell you if that looks abnormal or not. You will get that with practice, right? But some of the things to note here is that, we have what their normal range looks like. And is everyone going to fall within that normal range? No, right? So if you guys ever took a statistics class, these guys look like a normal distribution, right? The kind of the bell-shaped curve, right? If you go out 2 standard deviations, how many people fall outside of that? 2.5% on either side. Yeah, so 5% of people will fall outside of 2 standard deviations of a normal lab value. So it's important to remember that when you're looking at lab values, even though a person may come up as abnormal, they're outside of the normal range, that could be their normal, right? So it's always important to remember that some people will just be outside of the norm, just at baseline. And that's okay, right? Because everyone's a little bit of a snowflake. But other things to look at is one, like kind of the normal ranges that people can fall within. Notice how tight some of these controls can be. So for instance, with sodium, you have a decent range, say between 135 and 145. Normal ranges will depend on where you're working as well, right? So which lab you're working with, they'll report out normal ranges, and so that can differ between place to place. So again, I say 135 to 145. Here it lists 138 to 146. Pretty close, right? But other things are going to be kept in much more tight control. So things like serum potassium. Notice there between 3.8 to 5. That one has to be kept really, really tightly regulated, because if our potassium goes too high, we can end up running into arrhythmias, right? So you can see heart problems that can develop from that. And so that's really, really important for kidney patients, especially. But another thing to note here as well is that we're going to be looking at the units. Okay, units are so important. A lot of people don't really appreciate that until you can run into a problem, right? So a good example of this in the toxicology world is with aspirin overdose, right? So someone overdoses on aspirin, you can cause all kinds of really bad problems, but we can measure blood levels of aspirin to tell us kind of where they're at, right? To see how high their level is. And so the way that we normally measure aspirin levels is in milligrams per deciliter, okay? Normal range would say between 15 to 30. So if I took, say a gram of aspirin, I'd be somewhere between 15 and 30 milligrams per deciliter. Okay. Now on the other hand, if you were to get up to like a level of 100, that would be imminently like fatal, right? So you can see seizures, metabolic acidosis, all kinds of problems. Like that's a big deal if you see a level of 100. Now I was on the phone with the hospital, and at the poison centers we handle lots of hospitals in North Central Florida. So I was talking to one. I said, "Oh, what's their aspirin level?" And they go, "Oh, it's 400." And I go, "Oh no, is that patient dead? Like that has to be a post-mortem reading, right?" And they're like, "No, they're fine. They're just breathing a little fast." And I'm like, "Okay." I go, "What units is that in?" And they say, "Oh, it's in micrograms per milliliter." Okay, when you convert that over, it turns out to be 40 milligrams per deciliter, which is above the normal range, but still not like scary levels, right? So it's important to really look at your units, make sure those are going to be you're using the right ones, and you're interpreting that appropriately. So, and again, like things like, serum sodium, here they have it millimoles per liter. Everywhere you work, it's going to be milliequivalents per liter. So it just depends on where you're at and how they report it out. So anyway, any questions on that? You'll get much more about lab values as you go through the course, especially I think Dr. Butler will be talking about that probably next. Okay, so anyway, so how do we help to regulate this function? There's a couple of different ways. We can use the nervous system, right? This will be primarily through our sympathetic nervous system and also the parasympathetic nervous system. How would you differentiate those two without looking at the slide?
Sympathetic starts with a P, and so does pillow.
Pillow. Okay, so parasympathetic starts with a P, so does pillow, and that means what?
Rest and digest.
Rest and digest. Okay, that's a good way to do it. I've never heard that one before. What about sympathetic?
Fight or flight.
Fight or flight. Yep. Think about if a bear hopped out at you all of a sudden, sympathetic nervous system is going to be activated, right? So that's immediate, like we need to do something about this kind of thing. Absolutely, so those are good ways to remember that. And you also can have the endocrine system helping with this as well. So if you had to think, which one do you think would be faster, the nervous system or the endocrine system? Yeah, nervous system is going to be faster, hands down. You're going to see immediate changes after the nervous system is being activated. The endocrine system, on the other hand, can be fast, can be very slow in some cases. For instance, the thyroid glands, right? So if you notice, if your body was detecting there's not enough thyroxine around, there's not enough, metabolism going on, the person's kind of sluggish and slow and all that, and the body needs to respond to that, it can take weeks to really get back up to a normal level, right? And so endocrine tends to be a lot slower than the nervous system is going to be in most cases. Good example of kind of neural control of some of these homeostatic processes. Imagine a person's laying down and they go to standing up immediately, right? So what do you think that does to their blood pressure? Should drop, right? Especially to what organs? The brain, and where else? Or the heart, right? So always think about, blood flow wants to go to the heart and the brain. Those are the two organs we probably should keep functioning if we want a person to live, right? So you can find that the blood maybe have been pooling while they're lying down. They stand up real quick. They're going to have a lot of blood on the periphery. We need to get it back into the central circulation. We need to get it back to the heart, back to the brain, right? So the blood pressure falls. That's our stimulus, right? So those baroreceptors we mentioned before, those are going to detect that. All right, we have hypotension developing here. The blood pressure receptor is going to respond. That's our sensor. You're going to have these nerve fibers. Which nervous system do you think is going to activate when you have hypotension like this? A parasympathetic or sympathetic? Yeah, it's going to be sympathetic, right? Because again, low blood pressure. If a bear hopped out, you're going to want blood pressure to run away, right? So again, that'll be the sympathetic nervous system. The medulla oblongata is going to be able to integrate this. It says, hey, blood pressure is too low. These receptors are telling me so. And they're going to be able to reflexively activate the sympathetic nervous system. And it can do things like vasoconstrict. You see blood pressure go by constricting the blood vessels. It can also affect the heart as well. You have stronger contractions. We can have it beating faster. And that can also help to drive up the blood pressure, right? Once that occurs, once you're back up to a normal level, that's that negative feedback. Those baroreceptors say, hey, we're good. The medulla is going to stop kicking out those sympathetic nerve signals, and then you're back to normal. Okay. So again, this is going to be a very fast process that occurs when you're dealing with the nervous system. Again, how long do you think this whole process takes? Seconds, right? Who do you think this might be slower in? Yeah, a lot of elderly patients. So what do you call that when you stand up and you have low blood pressure? Yeah, orthostatic hypotension. So we see this a lot, especially with older patients who have like multiple medications on board. So say, for instance, you were on medications for dementia, or you were on medications that were affecting your blood pressure, like antihypertensives. They stand up, they have a really kind of impaired ability to respond to that, and so that can lead to what do you think? How do you feel when you get orthostatic hypotension? Dizzy, and then syncope can happen, falls can happen, fractures can happen, very, very bad stuff. So again, that's one of the big things you look at with your old patients is what's their fall risk, right? So that's where looking at their medication list, looking at disease states to see if they're at risk for these kind of falls is very, very important. Because if you are taking care of a patient, say in the hospital, and you give them medications that cause them to have orthostatic hypotension, they fall and break their hip, Medicare is not going to pay for that, right? Because it happened inside the hospital. Now that's your problem, and the patient's going to have a really significant impact on quality of life. So it's really, really important to look at these kind of effects. I'm going to have a lot of digressions here, so hopefully you guys don't mind. Okay, so again, this is just kind of another way of illustrating the same point, just kind of looking at what happens when the blood pressure drops. You're going to have that initial sensors receiving that signal, send it up to the integrating pathway, and then it's going to send out another signal back to the effector, right? Hopefully it should be a very fast process. On the other hand, we can have the hormones responding to this. So hormones can be secreted in response to specific stimuli. So for instance, you have high blood sugar, insulin is going to respond by being secreted, right? How long do you think it takes for insulin to be secreted from the pancreas in response to high blood sugar? Things like seconds, minutes, hours? Probably minutes, because again, your body wants to respond to that because again, after you eat a meal, say after you go and eat breakfast after this, your blood sugar will rise, but it's not going to rise for several hours. It may rise for a half an hour or so and then go back down, and by the end of 2 hours, like you should be back at normal, right? So it's a little bit faster process, but not nearly as fast as the neural the innervation pathway. And again, that'll have that normal negative feedback loop. Insulin's going to help to bring the blood glucose levels down and help to inhibit further insulin secretion.
Is that also because it's the endocrine system, so it takes like minutes as opposed to the nervous system?
Exactly, yeah, because the pancreas basically is responding to those increased blood sugar. So basically, if you intake food, you're going to start to break down those carbohydrates. They have to get absorbed to the GI tract. The pancreas has to detect that in the bloodstream and then respond to it by releasing insulin, right? Versus if I have blood pressure drop like that, my sympathetic nervous system is going to respond immediately. Okay, so it's going to be just a slower process. So, and again, usually you're going to have some sort of antagonist to help to maintain this homeostasis. So we mentioned that glucagon and insulin basically have antagonistic actions to one another. One raises blood sugar, one drops blood sugar. They kind of live in harmony in a lot of cases. You will find, especially in certain disease states, so like type 2 diabetes in this case, you're going to have these patients who will have relatively low amounts of insulin. Type 2 diabetics, they're going to have very chronic high blood sugar levels because they've kind of altered those set points for a lot of those receptors. They have low insulin levels. In some cases, and they have very high glucagon levels, and so we'll look at the drug therapy for that next year or next semester, and we'll see how we can affect that with certain medications. Again, just another good way to kind of illustrate this point between the antagonistic effects of these. So if you're in an eating state, so if you're eating breakfast, again, your blood sugar is going to rise. Those pancreatic islets and those beta cells of the pancreas are going to be releasing insulin. What do you think glucagon secretion is doing during this time? Should be inhibited or stimulated? Should be inhibited, right? Because your blood sugar is going up, so you don't really need glucagon around. So you're going to cause cellular uptake of glucose to increase, right? That's also going to stimulate the liver to help produce glycogen because it doesn't, has excess glucose, so it can use that to store it up for later use, and that'll decrease your blood sugar. And that's going to lead to that negative feedback loop, right? That makes good sense. And on the fasting end, if you have low blood glucose due to fasting, again, you're going to have the alpha cells within the pancreas are going to release glucagon. Notice here you're also inhibiting release of insulin. So again, there's antagonistic effects. You're going to cause less cellular uptake of glucose. You're going to cause the liver to start secreting more glucose for your cells to use, and then you're going to increase blood glucose levels, right? So you're back to normal. Negative feedback loop will drop those glucagon secretions. It's pretty straightforward. Okay, any questions from the first half? Everything pretty much reviewed, nothing new for you guys? This is easy stuff. PA school, I got this, right? Wait till pharmacodynamics. Okay, so continuing on with body function, we're going to talk a little bit about different types of tissues. Again, this is kind of surface level stuff. We'll go into more detail when we talk about specific organ functions and whatnot later on. But these are the four main ones we're going to be covering first. As far as muscle tissue goes, we have three main types: skeletal muscle tissue, cardiac muscle tissue. Where do you think you find the cardiac muscle tissue? Probably in the heart, yeah. And then smooth muscle. Where do you find smooth muscle? Organs is a good one. Yep. So we'll certainly find those around a lot of kind of hollow organs, especially. Squeeze there. The skeletal muscle obviously is primarily under conscious control, which is a good thing. It means I can move my arms around, I can do all sorts of things, and essentially we're going to be working on causing these contractions mainly through the tendons, which connect the muscles to the bone, right? So those contract, cause movement to occur there. Again, we're going to go much more into detail on this when we get to the musculoskeletal system later on. Notice that a few muscles, skeletal muscle does not, they don't actually connect to any kind of bone, but they can still provide some movement. So, for instance, the esophagus, the tongue, diaphragm, things like that, even though they're not really moving bones, we still consider them to be skeletal muscle because the morphology of those cells is identical. Just some slides of actual skeletal muscle, how that looks. There's a very kind of like regular patterns. Notice that you can have multiple nuclei per cell. Again, most you have the cells that can become very large, and again they can respond to different types of stressors. So you can see hypertrophy that can occur or atrophy over time, depending on how you're using them.
Are we going to be tested on histology?
Not in this class, no, because I probably couldn't. If you actually put a gun to my head, probably detect a lot of different slides. It's just not my training, right? Yeah, so that'll probably be in a different class. You'll have that, but this is just more for illustrative purposes. I don't know that I contain any picture, or will put any pictures actually on my test. Just a lot of words. Yep. Next is our cardiac muscle tissue. Again, only found in the heart. These myocardial cells. What do you think makes these cells different than like your skeletal muscle? Good, yeah, so it's involuntary, right? Because I don't want to have to think about beating my heart. Otherwise, I'd probably fall over dead halfway through the lecture, right? What else is different? Yes, you can see some branching can certainly occur there. What else?
The intercalated discs.
Yes, the intercalated disc. I love intercalation. That's one of my favorite words to say. Yeah, so what do those intercalated discs do? Yeah, they kind of interconnect the cells between one another. That's really, really important because obviously the heart is meant to beat, and how do we cause that beating to occur? We have action potentials, and we have electrical signals that send that, right? And it's really, really important that those are concerted efforts to happen, because if I cause one big contraction all over the heart, it's not going to be very effective, right? So I need the pathway to occur from the atria down to the ventricles to make sure I have good flow of blood throughout the heart. That's where you want the lub dub. You don't want some quivering massive muscle, because it's not going to get blood flow throughout the body very well. So we'll talk about action potentials and how those occur later on, but it's really, really important we have this kind of concentrated effort to move sodium and move these action potentials throughout the cells appropriately. Again, just show you a little bit of difference here between the skeletal muscle to the cardiac muscle. Notice these discs here, you can see where I'm pointing to there, and the nucleus as well will be included in these cells. And then finally, you have smooth muscle. You're going to find these in a lot of hollow organs. So specifically, you can see like in the digestive tract, the urinary tract, lots of different organs. Blood vessels are going to be really, really important to maintain blood pressure and things like that. Notice these are going to be non-striated, and typically these are involuntary as well, right? So the two involuntary are going to be your myocardial muscle and then also the smooth muscle. You'll oftentimes will find them kind of going in different directions. Why do you think that is? So for instance, if you're looking here in the stomach, you notice there's like some longitudinal muscle, you notice there's some oblique muscle. What do you think that does for us? Yeah, so it allows for different types of squeeze to occur, right? So if it's just kind of one squeeze, it really wouldn't be all that effective, but if you can kind of gesticulate and move it all, undulate, and all kinds of other words to describe weird movement, that would be occurring there, so that's important. Oops, I don't know why I clicked that. So anyway, so this allows for things like peristalsis, right? So that's really the main word I'm looking for there. Allows for this kind of wave-like contractions to help to move fluid, move food, other types of things through these hollow organs and out to wherever they're going to be going, right? So if you don't have good peristalsis, say like in the GI tract, what occurs? You need to have constipation. Oh, what's another term for that? Gastroparesis can occur. Yeah, you can see that like in diabetics, where they'll actually have the inability to kind of move food through the stomach, so they'll vomit and actually look like whole food still because they haven't really been able to pass it appropriately. Anything else? Ileus is another term you can see there. So that actually is like kind of like a paralytic bowel. Basically, it's not going to be moving through. I know some of you guys may not have gotten that on your test, but I may have reviewed that one. So anyway, yeah, so lots of different places you're going to see this peristalsis. Really important for helping to push things through the system, right? And so if that's not occurring, then that can be a problem, right? Sometimes you can see that the muscle is actually going to be the issue. Sometimes the ducts and things like that are going to be blocked up. I see that a lot, especially like in patients with cystic fibrosis. You guys ever heard of that? Yeah, so it's primarily pediatric disease, and they actually have this really thick, tenacious kind of mucus that blocks up a lot of their organs. So they have like pancreatic dysfunction, they can have digestive system dysfunction due to the, even though they can have normal peristalsis, everything's just kind of blocked up. So again, here you notice just a little bit different histology with the smooth muscle tissue there. Okay, next we'll look at the nervous tissue. Primarily we're going to see that you'll have the central nervous system, which is primarily made up of the brain, the spinal cord, and you'll have their peripheral nervous system as well. Again, we'll go into much more detail on this later on, but primarily we're going to see this is going to be composed of the neurons and these neuroglia cells. They're kind of just these helper cells that help out with things. We'll talk more about the nervous system when we get to things like the sensory lectures. So this is why we kind of introduce these now, so at least have some kind of at least background on it. But these cells are going to be used to help conduct action potentials and help conduct these impulses. And it's really, really important to help conduct these type of signals, both up and down the neurologic system. Notice that the three main parts of these neurons here are going to be the dendrites. What do the dendrites do? Yep, they're going to be receiving signals, so they have lots of connections to the dendrite. Next, you're going to have the cell body itself, where a lot of the functional parts of the actual neuron are going to be. And then you have the axon here. And what do these do? Send the signal, right? So you can have axons that can be very long, very short, depending on where the signal is going to be going to. If it has to get down to your big toe, you're probably going to have a pretty long axon versus if it's just going to be kind of a short interconnection up in the brain, right? Lots of different neuroglia cells. These are just going to be helper cells that help either to do things like help control like the action potentials, make sure they're traveling appropriately. Some will be used for more immune function. Lots of different things. We'll get into more detail later on. Again, just a picture of a slide. You can see that neuron here. See the dendrites up at the top on the cell body, and then the axon itself, where it would be sending signals versus receiving them at the dendrites. And so this is another important thing to look at here, especially when we talk about nervous or sensory function and whatnot. These myelin sheaths that occur here. What's the point of having a myelin sheath along these axons? Yeah, so they help to speed up the transduction of those impulses along, right? So instead of having to, and again, what ion channels are really important for causing these action potentials to occur? Yeah, sodium, yeah, potassium will be important as well, but sodium is the main one that triggers a lot of these. So if you had to go from sodium channel to sodium channel to sodium channel, like, it would take forever to send those signals. And so you'll find that actually some of these neurons are going to be unmyelinated, and you'll find that those actually have a lot slower transduction times than you would see if it had a myelinated neuron. So those are going to travel a lot faster because basically you can jump from node to node to node. They call those nodes of Ranvier. So those provide a very fast conducting nerve tissue there. So that'll be more evident when we talk about this later and how that can be important there. You guys know any disease states that cause demyelination? Yeah, multiple sclerosis. That's it's an autoimmune condition. We're actually going to find that the axons end up becoming demyelinated. How do you think that kind of manifests as a disease? Yes, they have weakness, blindness in some cases. See a lot of, usually end up seeing a lot of kind of like peripheral effects as well. So like weakness, like pain is a really big issue to a lot of those patients. So from my standpoint, I see a lot of those patients filling a lot of opioid prescriptions and things like that to help kind of deal with, they have a lot of spasticity issues that can occur here as well because it can affect conduction down to the skeletal muscle tissue. So lots of problems that can happen there. But the root cause is you had the immune system kind of attacking these myelin sheaths and causing that demyelination there. Okay, next we'll have the epithelial tissue, and so this is going to be providing kind of the surface layer for a lot of different organs and tissues and whatnot. Usually you're going to find them lining kind of hollow organs, so you can find these lots of different places like the lungs, GI tract, etc., glands as well, and then also we're going to have these epithelial tissues on the outside of us as well, so that's providing our skin. You can classify these based on how they are basically laid out. So you can either have a simple kind of epithelial layer where you basically have just kind of a single layer of cells there. As you can see, it's pretty obvious. So again, don't provide a ton of protection. So you would not be, this would not be very useful to have like on the outside of your skin, right, on the epidermis. Like, because again, if you lost that one layer, then you're bleeding everywhere and it's no good. You'd rather have a stratified kind of organization there. So you can see if you have multiple cells there, you have stratified. Pseudostratified is just kind of a combination of the two, where you can have sometimes layering of cells, sometimes they're just kind of cells, different cell types kind of mashed together. You see this a lot like in the lungs. You see it also like in the GI tract, like in the stomach, things like that. So different cell functions that can occur within one type of tissue. But again, and then you'll have different kind of morphology of the cells themselves, whether they be squamous, kind of smaller cells, cuboidal, or then columnar, right? So you guys covered that before. Again, just varying tissues are going to have varying types of cells depending on kind of what their function is going to be in a lot of cases. Again, you can see how this kind of looks like. For instance, here you have the pseudostratified ciliated columnar epithelium. What do you think the cilia do? Kind of moves things along. So if you imagine like this would be like in the lung tissue where you have like goblet cells that are releasing mucus into the lungs that helps to clear debris and things. Those cilia help to kind of move things up, and that way you can kind of cough it out or swallow whatever you need to do. What do you think of some disease states that can affect those cilia? Or something like people may do? Smoking, yeah. So smoking a lot of those hot, noxious gases and whatnot can actually burn off a lot of the cilia, and they have all this kind of gunk sitting in their lungs they can't get rid of. And you can see COPD and bronchitis, that can occur with a lot of those patients. So lots of people doing bad things to their cilia. But again, those all need to move in kind of a coordinated fashion in order to help, kind of a similar kind of peristalsis kind of motion to get things cleared out of the lungs, because we want that to be a nice sterile area as best we can. Okay, we'll also see some exocrine glands. Again, exocrine, how do you think the difference is between exocrine versus endocrine glands? Yeah, it's outside versus endocrine glands would be secreting more kind of inside the body itself. So exocrine, and keep in mind like the GI tract we're still considering to be kind of like outside of the body, because it's not really, you have things like the pancreas, which can be also an endocrine and an exocrine gland, and things like that's probably one of the best examples of both an endo and exocrine gland there. But again, things that are secreting things out into the GI tract can also be considered exocrine as well. But a lot of those are going to be derived from epithelial tissues, and they get transported via ducts in a lot of cases. So you have things like the lacrimal gland be secreting tears, sweat glands, sebaceous glands. The digestive enzymes, those are the ones that come from the pancreas that are the exocrine function. So you have things like proteases, what do you think proteases digest? Protein, amylases, sugars, and then lipases. Fats. Yeah, so going back to those cystic fibrosis patients, they have a lot of problems with their pancreas gets blocked up, their ducts. They can't actually secrete protease, amylase, and lipase, and so they can't digest their food very well. So that's actually an exogenous drug that we give to them. We'll give them enzymes in these capsules so that can actually supplement that and replace that so they can digest their food and absorb it more readily. So again, just another example how some of these dysfunctions can occur here. The prostate gland can be considered an exocrine gland as well, because that's what provides some of the seminal fluid and whatnot. Sweat glands in particular, you can find there's two varieties there. You have both the ecrine and the apocrine. And so the apocrine is where you get more of the kind of protein-rich kind of sweat, usually in the axilla and the groin, things like that. That's where the bacteria feed, and that's obviously where bad smells come from, right? So hopefully everyone wore their deodorant today. Otherwise, your neighbors might be noticing if your apocrine glands are kind of in overdrive. Me being up here, it's very hot, so you may see that as well. Hopefully not the smell, though. Put that in reviews. Teachers smell bad, especially you guys in the front row. Important to know. Just some examples of kind of how these lie. And again, you can find both apocrine and ecrine glands kind of situated next to each other. It just depends. You usually find more of the apocrine like in the axilla and the groin. Okay. Next up, we have our connective tissue. So major connective tissue categories include actual like kind of proper connective tissue, cartilage, bone, and then the blood. So you never thought about your blood connecting stuff together, but it truly does. So again, you can normally find these connective tissues usually made up of some sort of like protein fibers, especially extracellular material, and also some specialized cells will kind of get involved with those. I'll show you some pictures of that in a second. But essentially, you'll have either loose or dense regular types of connective tissue. Loose, you can normally find it's a lot kind of looser conglomeration of different types of cells and whatnot. But a good example of this would be like the upper layer of the skin. When you look at pictures of that, there's all kinds of different cells there. There'd be protein. There's going to be blood vessels, nerves, all kinds of different things kind of held together by this connective tissue versus like dense regular type of connective tissue. So an example of that would be like the bones, right? The bones are very uniform for the most part, not very kind of hodgepodge mix like you would see with the skin. Also have like adipose cells, which obviously are going to contain their fat. So an example of like a loose connective type tissue. Notice here you have things like elastic fibers. You can have blood vessels. You can have nerve tissue. All of that very kind of loose connection of all of those. Versus if you were to see something like the bone. Or actually, these are adipocytes, adipose tissue, or you can keep the fat. Again, that could be considered kind of a loose connective type tissue. But then we'll have the bone here in just a second, where you can see it's going to be much more kind of like densely packed, which you want, right? Because you want your bones to be nice and strong for the most part. And that usually occurs from things like the osteoblasts, which are important for kind of laying down the bone tissue. They help to capture those salts, like things specifically calcium. Calcium is one of the major components there, kind of laying down this calcified tissue, right? And so once they kind of are hardened, once the osteoblasts have kind of done their job, then they turn into these osteocytes, right? You guys know what cells break down bone? Yeah, osteoclast, right? So you're going to find that also is going to be a very important negative feedback loop where you have the osteoblast and clast kind of working against one another to maintain what levels within the body. Calcium, right? So again, we find that this kind of can become deranged, especially when you're dealing with, like, say, older women. They develop osteoporosis, right? Yeah, because they maybe can't maintain their calcium levels appropriately, so you end up having too much osteoclast activity, breaks down bone, they get osteoporosis. Men can get it too, but typically, again, you're going to see it more in your female patients. So just an example of what the bone tissue is going to be looking like. Again, for the most part, much more of that kind of like dense, kind of packed connective tissue there. Okay. So again, when you get multiple types of tissues working together, that's when we develop an organ, right? Not the kind you play in church, but multiple tissue types here. And they're going to have different types of functions in a lot of cases. So the skin, obviously being one of the largest organs in the body. Everyone, your epidermis is showing. right? I don't know if you remember that from elementary school. But anyway, so obviously broken down into three major layers. So you have your epidermis, which is going to be the kind of the outside layer. Again, we want this to be this keratinized, stratified squamous epithelium cells, right? Because that helps to prevent us from desiccating, helps prevent water loss and invasion of organisms, right? So it's our primarily protective organ there. You have the dermis, which is going to be more that dense, irregular tissues. You're going to have lots of different things like nerve fibers and blood vessels and different things all connected together. That's where you see your hair follicles and whatnot. And then finally, the hypodermis is going to be your kind of fat layer, provides nice insulation, prevents for heat loss, and also nice cushioning there. Some of us may have more cushioning than others, especially after you have a baby, you tend to develop a lot more cushioning. Not sure if it's endocrine related or just bad food choices. Probably the latter. Anywho, so again, looking at the skin here, you can notice kind of the three layers and how those kind of differentiate between one another. Again, working together form one organ. Okay, once we have multiple organs playing together, then we have a system, right? There's 11 major systems we're going to be dealing with, and again, we're going to go into these in more detail as we go forward throughout the course. One is going to be our integumentary system, so that includes things like your skin, your hair, your nails. Obviously, we mentioned they provide good protection, thermoregulation. You have your nervous tissue. We'll talk about that as far as the senses go in a few weeks. It helps to regulate a lot of different organ functions. Basically central command for the body, right? Endocrine, obviously, we'll talk about that in a few lectures, and that's going to be able to control lots of different things. Usually more of a slow process, but it helps to maintain homeostasis for lots of different things. Skeletal system, muscular system, we'll go into more detail on. The circulatory, so that's we'll spend a lot of time there because you're going to find a lot of patients have circulatory system issues, right? Either with the heart or the blood vessels, whatever happens to be. Immune system, a big one we'll talk about. Respiratory, urinary, digestive, and then reproductive. So again, all these different systems interplaying together to make you a person, right? All right. So any question on kind of the basic function of the body? Everyone's like, that was easy. Got this PA thing down. Okay. Hopefully you guys like chemistry because we're going to go a little bit into chemical composition, just some of the basics. I will try to illustrate to you why this is super important. Being a pharmacy nerd myself, I don't know that I'll be able to appropriately communicate that to you. But okay, so obviously an atom is going to be the smallest unit of an element. Okay, it's going to be made up of the nucleus, right? So obviously this nucleus will be a little different than when we get to a whole cell, but it's going to contain our protons and our neutrons. And then obviously we're going to have electrons that are going to be circulating outside of that. Okay, so an example of we have like sodium here. You notice that it's going to have 11 protons here. It's going to have 11 electrons, and then 12 neutrons in this particular case. So two things to note here. The atomic mass itself is going to be equal to the number of protons plus the number of neutrons, right? Because electrons don't really weigh much. And so for carbon, you would see that would be 6 plus 6, right? At least for that particular isotope. Sodium, on the other hand, if you were to combine the neutrons plus the protons, it would end up being 23. Okay, that's the atomic mass. That'll be different than what the actual atomic number is going to be, and that's going to be based primarily just on the protons, right? So if I were to ask you, say, like on a test, what the atomic number of carbon would be, you'd say 6, right? Versus if I asked you what the atomic mass would be, you'd say, oh, that'd be 12. Okay, so examples like that. And I will give you like the neutrons and the protons and electrons and all that to try to help you to determine that. Okay, again, you're always going to have the same number of electrons as protons, at least when you have the atom by itself. Correct? Anyone with a chemistry degree, feel free to correct me. Okay, so a good example comparing these two. So hydrogen, obviously being a very reactive element, just one proton, one electron, very kind of basic element there, versus carbon, you end up having 6 protons, neutrons, and then 6 electrons, right? So the protons and electrons should be kind of paired off there. Some of our more common biological atoms you're going to run into include hydrogen, carbon, obviously nitrogen. We breathe in a lot of nitrogen in our body, oxygen. Very important element, as I'm sure you guys know, and then sulfur as well. So you can see some of the differences there. Why do you think the number of electrons in the outer shells matter? Yeah, so reactivity is going to dictate how they bind, if they bind at all. We're going to find some things are very stable by themselves because we're going to look at their electron shells to see how filled out they are, right? So the more filled out it is, once it's filled out, it's not going to be very reactive. So that's where you have like your noble gases, things like that. They have a full electron outer shell there where they don't really react with much. Okay. one time Argon walked into a bar, asked the bartender for a beer, and he said, "Hey, we don't serve noble gases here." Argon did not react. Okay. Trying to make this as interesting as possible, I swear. Okay, so anyway, we mentioned the electron shells. That's basically just going to be the outer shell, or a series of shells where the electrons are going to be circulating there. And again, typically that first shell is going to be 2 electrons. Okay, so we noticed with like hydrogen, notice it only had 1 electron that was floating around there. But if you were to have, what's the next element up? Helium, right. So, you know, the dead chemist, if you can't helium, you got to barium, right? All right, right. So that would have 2 electrons. So that would be a much more stable element than you would have with hydrogen. It only has like 1 electron out there. So the first valence there is going to have 2 electrons. Everything outside of that is going to have 8. Okay. If it has less than 8, it's going to be somewhat reactive. You can either combine it with itself in some cases. It's going to combine with other things, and we'll see how those combinations occur. And then we'll see there's a few different types of bonding that can happen there. So again, they're most stable when these shells are going to be filled. So for instance, sodium chloride, which another name would be salt. Yeah, so just normal. I mean, really, salt is kind of a broad category, but yes, we would call it table salt, right? So sodium chloride, they like each other because when they kind of combine to one another, and do you guys know what type of bond that would make? An ionic bond, yeah. So we'll look at what that is in a second. But because sodium is going to have that 1 electron kind of sitting out there on its lonesome, because again, note we said that sodium is going to have 11 protons. This is going to have 11 electrons. So it filled up the first electron shell there with 2. It's going to have 8 here. So 2 plus 8 is 10, and then you have that 1 lone electron there. It helps to combine with chlorine because chlorine only has 7 out there in its outer shell. So those guys like each other because they complement one another pretty well. Notice here how H2O is formed, or dihydrogen monoxide. It's a good way to tell people, listen, we have a leak. Dihydrogen monoxide, very dangerous chemical. Okay. So yeah, so you have water that can develop here. Again, hydrogen having only 1 electron in its outer shell is able to react pretty well with oxygen, who needs 2 electrons to fill out its outer shell. Right. So there's going to be, what type of bond is happening here? Do you think? Yeah, it's much more of a covalent bond, right? Because these guys are sharing electrons versus here you're going to see that sodium is going to give up its electron over to chloride or chlorine. So again, these bonds are going to form whenever these electrons are interacting with one another. And again, the number of bonds that can form is going to be dependent on those valence electrons that happen there, right? So again, hydrogen only needs that 1 to fill that inner shell. So typically hydrogen forms just 1 bond to something, whether it be carbon or oxygen, whatever it happens to be. And then carbon itself needs to fill up that, we'll end up having 4 bonds because it's only filling up 4 of its outer shell, right? So that's why you can have, you know, if you guys remember back to organic chemistry, who took organic chemistry? Most people did, right? Carbon binds how many things? 4 things, right? So you can have 4 bonds there. So again, it's just filling out its outer electron shell. Pretty basic stuff. You can see just another example of how these look. Again, there's the hydrogen atom itself, being only have that 1 electron. It's very, very reactive and can hook up with the oxygen pretty easily, and then we got water. Okay, so these covalent bonds are going to be shared between one another, so they like to stick together, as opposed to the ionic bonds. We'll see that they can kind of separate out from one another to some degree, but we're going to find that with water itself, it's a very, very important way that these connect together. The fact that the hydrogens are going to kind of sit here on one side of the oxygen versus the other, so we're going to find that it's going to have kind of a slight positive charge on one end versus a slight negative charge. What do you call this type of molecule that has kind of an uneven charge distribution? Polar, right? So the fact that water is polar is super, super important because we probably couldn't survive if water was not polar, right? Things would not dissolve very well in it otherwise. You also find some of these covalent bonds can happen. You can have atoms form with one another, so you can have H2 that can happen here. Oxygen obviously does that as well. So O2, is a very, very important molecule for us to be breathing all the time. So again, we'll look at the difference between polar molecules and nonpolar molecules, and this is actually super important for looking at how things are able to cross biologic membranes. Things that are very polar are not able to cross biologic membranes very easily. So we'll talk about hydrophilicity versus lipophilicity and all of that, and how that can pertain back to our medicine specifically. Again, notice here this would be a non-polar covalent bond between hydrogen, because again the charge distribution is going to be pretty even between the two, versus here with water it's going to have that polar covalent bond. This allows for dissolution of a lot of different substances, allows for salt to dissolve in it, things like that. Okay, then we have our ionic bonds. This is important for a lot of salts and things like that. So especially like in your bloodstream, if you imagine there's lots of different ions and elements that are floating around there. So this is where chloride is going to take an electron from sodium, and they're going to complement one another because now both shells are being filled. Notice they're not really connected to each other, loose association. But these things like this that form ionic bonds are able to dissolve in polar substances like water, right? So that's kind of nice because they go into solution and they can be used to go into cells and do all kinds of different things for us. Right. So again, water is a very good solvent. Substances like to dissolve in it, which is a good thing for us because otherwise, if everything was precipitating out, form all kinds of emboli, it's going to be no good, right? So we don't want that to happen. So we like to have things dissolve in that. Now, nonpolar molecules do not typically dissolve in water, so we call those hydrophobic. What would be another name for that? Water hating, yep. But if it's hydrophobic, what does it like to do with lipids? Be lipophilic, right? So you're going to find that there's a kind of a balance between, if something is very hydrophilic, it's typically lipophobic. Something that's very hydrophobic is typically lipophilic, right? So it's kind of on one side or the other, and that's going to be really, really important when we're talking about absorption of substances in the GI tract. It's important when we talk about the blood-brain barrier that helps to keep substances in or out of the CNS. So we'll talk much more about this probably ad nauseum. So bring your medications if you need it. But it's important because our cells typically are made up, and we'll talk about how the function and structure of them are. They're trying to keep things out in a lot of cases, right? So they'll find some things are going to freely flow through cell membranes, but we like to keep some things out, some things in. And it would be related back to how hydrophobic or hydrophilic these substances are, right? So nonpolar things that do not dissolve in water typically are hydrophobic. Things that are polar and they dissolve in water are going to be hydrophilic, okay? And then on the flip side of that, things that are hydrophilic are lipophobic. Things are hydrophobic or lipophilic. Philic-phobic, you guys will probably muttering that stuff to yourselves tonight when you go to sleep, but that's okay. You can see how the sodium chloride crystals itself, when it gets broken up into a solution and goes into water, there's how the negative portion of H2O is going to be surrounding the sodium versus the positive portion going to be complementing the negative aspect of the chloride, right? So just really complementing one another, breaking into solution, it's able to dissolve very easily, right? So you put table salt into water, what happens? Dissolves, right? It doesn't disappear, just dissolves, still there. What happens if I put too much salt into there? Eventually you can supersaturate it and it's going to be at a point where it can't dissolve any more salt and then just kind of form at the bottom. So it's important to note that how well it can dissolve things is there's a capacity to it, right? At some point you can kind of overwhelm that. Again, just showing this picture here, how the negative portion of H2O is going to be complementing the positive nature of sodium, which would be, is that a cation or anion? Cat. I always think cats are positive, even though they're really not. They're kind of negative. But but the chlorides are going to be the anion. That's going to be negative. The positive portion of the hydrogens of water are going to be more attracted to that. Okay, and that allows it to go into solution because it's being kind of enveloped by that water there. Okay, we can even see that the water itself that is, say, in our body is able to ionize as well. So we can see that there's a careful balance between having actual H2O and having it break up into a hydroxide molecule and a hydrogen, just a proton, right? And so where do you think this comes into play? pH, yeah, so this is super critical to pH. You guys remember the Henderson-Hasselbalch equation? I hear a few like, ugh. We'll talk about that again, don't worry. Yeah, so essentially if you have too many hydrogen ions, that typically makes the solution more acidic. If you have too many hydroxide ions, that typically makes things more alkaline or more basic. And so looking at the number of hydroxide ions versus hydrogen ions can give us an idea of what the pH of a solution is going to be. And so it's really, really important that we maintain ourselves within a pretty neutral pH for the most part. And we say a neutral pH is going to be? Yeah, so 7 would be absolute neutral. What's kind of the end of the scale? Like 14 would be basic or acidic? It'd be very basic, right? And then 1 would be very acidic, right? So we don't want to be on either end of that scale. We would like to be right close to the middle for the most part. Does anyone know what a normal serum pH is? Usually 7.35 to 7.45. So if you said 7.4, you're right in the middle there. So that's usually a pretty good range to keep people in. If you go outside of that, that's where we can start to run into some derangement. So I mentioned, we said the type 1 diabetics, they can go into diabetic ketoacidosis. Sometimes they'll come in when they're really, really sick. They can have a pH of 6.9. And that is very, very far away from what the normal is. They can be very, very sick because of that. You see all kinds of problems that occur, especially with like proteins. They can find that they can start to denature, all kinds of issues that can happen when that occurs. So it's really important that we make sure we maintain ourselves in a normal pH. So again, you can look at different, and we don't just emit neutral substances, right? We can have some different things that have different pHs based on the type of tissues that we're dealing with. So say for instance, you have things like gastric acid, which would be put out by what organ? Stomach, absolutely right. So that's going to be very, very acidic. And what does that do for us? To break down food, helps to dissolve that, and then obviously you don't want to have a pH of 1, a substance like pH of 1 going through all of your organs because it could cause damage, right? So you're going to find that the body has ways to neutralize that, to secrete bases. So where does that normally happen? So past the stomach, you go into small intestines, like the duodenum is the primary place where you're going to be secreting a lot of things like sodium hydroxide and things like that to help neutralize that pH to make sure you don't have a lot of acid going through all your intestine and kind of rotting it out, right? You don't want that. So you're going to find that the body's able to neutralize some of that to some degree, right? Not always, because in some cases you can have too much acid being produced in the stomach, and that gets into the small intestine. You guys know what that can cause? Cause ulcers to form, right? So in some cases we may actually have to give things that block production of acids, or we can give things that can neutralize acid. So if you guys have say some reflux, say you go to an Indian restaurant and you get something super spicy, you knew you shouldn't have eaten it but you did anyway, you get the kind of reflux, like what do you take? We can take a PPI. We'll talk about those in pharm, but more easily you take Tums, right? So Tums is just calcium carbonate, so it's actually an antacid, right? So it helps to neutralize that pH, and so it's helped deal with a lot of that reflux that you're having with that. So again, we can use medications to do that. Our body can do that to some degree as well to help kind of maintain normal pH levels. Okay, and again, we can measure different pHs. Usually we use litmus paper to help with this. Sometimes you'll see like gastric acid probes being done to see what pH is in the stomach. I do this frequently, like in the eye. If I were to ever have someone from a tox perspective have like drain cleaner, has a very, very neutral or a very basic pH. Sometimes people get that in the eye. We actually will measure the pH of the eye to make sure they're not causing any damage there. But just keep in mind that when you have something that's more basic, so above 7, you're having a higher concentration of hydroxide ions, versus when you're going more acidic, below 7, you're going to have more hydrogen ions, right? So based on that, you can actually see the dilution of substances will change. Some things like to be in acidic milieu, some things like to be in more basic solutions, and they dissolve differently based on that. So we'll look at that more in pharmacodynamics probably. But just keep in mind, normal pH, we like to keep it in the range 7.35 to 7.45 typically. Again, usually pure water would have a neutral pH of 7, but normally you're going to have some contaminants and stuff. Let's see if I deionized water. But again, 14 is going to be the highest we can have. pH of 1 usually is kind of the lowest you can have there. But again, increasing the hydrogen ion concentration is going to be more acidic. Increasing hydroxide ions is going to make it more basic. We have lots of buffers that are available to help regulate the system as well. So bicarbonate is going to be one of the primary buffer systems we see in the body to help maintain this. So for instance, we have a nice interplay here between carbon dioxide. There's carbon dioxide and water. This can be changed over into carbonic acid, which can then donate hydrogen ions and form hydrogen ion plus bicarbonate. And so you can see there's a good interplay between this in order to make sure that we're maintaining our serum pH at a pretty neutral level, right? So for instance, if we were to have, say, too acidic of blood, so we have too many hydrogen ions, what you're going to see is that will actually combine with bicarbonate and force this reaction over into this form over here to carbonic acid, and then there's an enzyme we'll talk about probably later on at some point that will actually convert this over into carbon dioxide and water. And then what do you do with carbon dioxide in the body? Exhale it, right? So that's our body's way of maintaining normal pH, is by combining excess hydrogen ions with bicarbonate and then breathing it out as carbon dioxide, right? So that's one way we can help to buffer our system. On the other hand, though, if we were to say, if we were too basic, right? Sometimes you're just a little too basic in life. talking about pH right now, you can see that you can actually drive the reaction the other way, right? So you can actually see we'll take carbon dioxide, convert it over to carbonic acid, and then actually donate these hydrogen ions, right? And so that is another way we can help to maintain that buffer system. Typically, people tend to err on the side of being too acidic, and so it's important to have that bicarbonate around to help deal with that and help neutralize it. But there are certain medications we can use to affect this. Sometimes we give people extra bicarbonate in order to help bring their pH back up. So lots of different cases where we can try to affect this for our patients. So again, if we have a patient whose pH drops below 7.35, we would consider it to be acidosis, right? Consider it to be acidotic patient. There's two varieties of acidosis typically. You guys know the different types? Metabolic and then respiratory, right? So what's a respiratory acidosis? What do you think that would mean? Yeah, so we have too much carbon dioxide, right? Because again, when you have too much carbon dioxide, it's going to be driving that reaction back over to releasing more hydrogen ions. And so it can be a case where if a patient was not breathing appropriately, right? So if you like say did something to stop the respiratory drive or had something blocking the airway, that would hold on to too much carbon dioxide and would cause too many hydrogen ions to be released, and they have a respiratory acidosis, right? On the flip side of that, you can have a metabolic acidosis where you can actually have the tissues generating too many acids, especially if you think about like anaerobic exercise, right? One of the major byproducts can be lactic acid, and so that can be another thing that can cause a metabolic acidosis, right? Lots of different causes for acidosis, but that would be one of them. And then you have alkalosis if you end up going too high. So what are the two varieties of alkalosis? Yeah, metabolic and respiratory. So how do you think I could have a respiratory alkalosis? So I get rid of too much CO2. So I see this a lot with my aspirin overdose patients that actually causes their respiratory drive to speed up, and so they're breathing it off too fast. And that gets rid of all that CO2, and that causes the alkalosis to occur because you have too much bicarbonate at that point. There's usually not a whole lot of metabolic alkalosis that occurs in a lot of cases. Usually end up seeing more metabolic acidosis, but it can occur as well. So just keep in mind there's some varieties there, but the body's trying to maintain homeostasis, trying to maintain that normal range, but there's lots of cases where it can kind of go outside of that, right, based on disease state or based on other things. Yeah. Everyone with me so far? Again, this is all review for you guys, I'm sure. Okay, so next, some other major molecules we're going to be running into include our carbohydrates. So again, what do we use carbohydrates for? Energy, yeah, absolutely. So we're going to go into energy production. We'll talk about ATP and all that fun stuff in a few lectures. But carbohydrates are going to be one of our primary sources for energy because these are going to be able to donate lots of carbons for that. Typically, it's an organic molecule. It's simply made up of carbon, hydrogen, and oxygen. And you'll find that you find these a lot in your foods as both sugars and also starches can be there. And usually you find the OSC suffix added onto those. So if you think about like what are some example like carbohydrates you can think of? Glucose, fructose, lactose, sucrose, dextrose is another good one. So so all the oses are typically going to be your carbohydrates you're going to be dealing with. So you can have monosaccharides and you can also have polysaccharides. Poly is just going to be anything more than one, but typically if you have two, that's going to be a disaccharide. So some good examples, these monosaccharides are going to be things that just have one carbon ring. It's very simple sugars, things like glucose, fructose. They can be broken down very easily for energy. Versus some of your more complex carbohydrates, there's usually going to be multiple carbon rings that are formed together with a covalent bond. Those take a little bit more time to break down. So the larger the carbohydrate, the more time it takes to break down to get energy out of it. But things like sucrose, maltose, lactose all fall into that disaccharide format. So again, you can see the kind of the straight chain format for these. So you have like glucose here. Normally, in a lot of cases, you'll see them form these kind of carbon chain or carbon rings in kind of their natural state. When you link these together, when you get those polysaccharides to form. But again, here just single by themselves are just monosaccharides. And what type of enzymes do we say would break these down? Yeah, amylases are going to be really important for doing that. So if you have a lot of complex carbohydrates, things that have they're polysaccharides, you can break them down with amylases to help break those bonds and get them more in a ready form for energy production. Again, disaccharides, you can notice here how they have this covalent bond between one another. At the oxygen here, sucrose is broken down into both glucose and fructose, lactose into galactose and glucose. You don't have to memorize that, but just know that if I say like a disaccharide, it's going to be two of those carbon chains put together.
don't need to know the biochem behind.
We will get to some biochem stuff you will need to know.
Like
I will.
The alcohol's on.
No, I'm not going to get into that necessarily. I'll make it pretty clear what you guys need to know for testing purposes. I try to be pretty fair with that stuff. Do you guys want a free answer on the test?
Yeah.
Okay, B. Okay. Anyway, so again, with our polysaccharides, again, usually it's going to be several monosaccharides just linked together. Generally, glucose is going to be one of the primary constituents of that. Starches are just going to be kind of a plant form of sugars. There are thousands and thousands of glucose molecules kind of put together. Glycogen's our main storage of glucose, right? And we say glycogen's produced where? Yeah, the liver is going to be one of the main places where glycogen is actually made. Some other cells can form it as well to store up energy, but the liver is going to be really important there. And then cellulose is just basically where the cell walls of the plant formed a lot of these starches. Again, usually not digestible by humans for the most part. Here's an example of what glycogen looks like. Notice it's just a lot of these glucose rings put together. Notice it's pretty wide branching. If the body needs extra energy, you would have glucagon being secreted. Basically, liver say, hey, we need some of this to produce glucose, so just cleave off some of it, and then boom, you have gluconeogenesis, right? We'll go into more detail on that, but just an example of what glycogen kind of looks like. Just a long, long sugar chain. Next we have our lipids. Typically lipids are going to be non-polar hydrocarbons. So lipids would be hydrophilic or hydrophobic? Phobic, right. So again, if they're lipids, obviously they're going to be lipophilic, right, because they like each other. But they're going to be hydrophobic in a lot of cases. And this is going to be really important when we talk about cell walls and whatnot. But typically they're going to be insoluble in water, right? So this is, I think, about mixing like oil and water together. Notice they don't like each other because, again, the oil is going to have a lot of lipids and it does not dissolve very well. There's going to be lots of categories we're going to be talking about. So, for instance, we have our triglycerides. I'm sure you guys have heard of these before. It's going to be really important. They're going to be including both fats, which can be considered like your solids, and oils, which are just more in kind of a liquid form. And again, depends on how it's going to be dissolving within the solution that it's in. Typically, you're going to find, I'll show you a picture in just a second, there's going to be one glycerol molecule, and you're going to have 3 different fatty acids that are going to be connected to it. So again, triglycerides kind of makes sense. And again, fatty acid, if it has every single carbon, molecules have 4 everything is kind of trying to think the word. Yeah, everything is single. Thank you so much. If everything has a single bond to it, that would be considered to be a saturated fat because you can't really do anything with any of those carbon bonds. It becomes a unsaturated fat when you have some double bonds that are happening there, right? So I'll show you some pictures of that in a second. So again, with our triglycerides, you have your glycerol molecule here. This will end up being bound to the fatty acid, and then you have basically your triglyceride is being formed. Notice these can be broken off and used for different things. Sometimes lipids can be used for energy production, used to produce new cell walls, used to produce hormones, all kinds of different things we can use these fatty acids for. Right? And just an example of a saturated one. Notice here, all single bonds. You can't really do anything with it. It's not as reactive as it would be if you had some of these double bonds here, right? So I can do things. I can make some reactions happen with these double bonds here. So just be an unsaturated fat, usually what's kind of healthier for you. Unsaturated fats are usually healthier for you. You think about healthy fats, you think about unsaturated fats, because you can do things with this. You can actually react to, like, kind of once you have a saturated fat, like, it's kind of just there, and so it usually gets stored up for energy production later or different things. So you usually think about unsaturated fats as kind of your healthy fats. Okay, so ketones are going to be really important as well. We kind of alluded to these when you're talking about like diabetic patients and that diabetic ketoacidosis. But basically, when you have hydrolysis of these triglycerides, they're going to form free fatty acids. So basically, just cleaving off the fatty acid off of that glycerol molecule, and then you can end up using these for as a replacement for glucose for energy, right? And so you can end up producing these ketones within the body. We'll talk more about this in detail when we get to energy production, but just note that usually you find ketone production occurring, especially in fasting states. So say, for instance, like you don't eat for a long period of time, say like 24 hours, and your blood sugar levels are dropping, your body needs to, if you don't have a lot of glycogen storage, your body's going to start to use other means to get that energy. And so usually it's going to start to resorting back to fat, and that's where you can get some of those ketones being formed from metabolizing that fat in order to get energy. So again, we'll go into more detail on that in just a little bit. That's where your ketones are going to be coming from. So again, you normally will see ketones being formed in low carbohydrate diets. If you think about things like Atkins, think about keto diets, things like that. They're specifically trying to put your body into a state where you're relying on a lot of these triglycerides in order to generate energy, right? So that will cause lipolysis eventually, cause the fat to break down, and hopefully you lose weight, right? One thing you see with some of those diets. You actually end up finding that a lot of these ketones actually form acids, and you can actually drop your serum pH using that. So that's where you see that diabetic ketoacidosis. Those patients, they basically have no insulin, and so their body resorts on using a lot of fats and muscles and things like that to produce these ketone bodies for energy, which actually end up finding that it causes the pH to drive down, gets more acidic, and they get very, very sick from that. This is one thing we want to avoid. Usually we'll end up giving them insulin to help kind of restore normal glucose use for a lot of those patients. Does anyone know what your breath smells like when you have in ketosis? Acetone smells fruity, yeah. So that's how one way you could actually tell if a patient was in DK is you can smell their breath. Obviously, it's not the definitive way you want to do it, but as one way to do it. You smell their breath, so it's fruity. You think, hey, that's acetone on the breath, probably in some degree of ketosis, right? We actually had some patients over at Nemours, children who have intractable seizures. And so one of the things you'll find is that in slightly more acidic pHs, you have a higher seizure threshold. It's more difficult to cause a seizure. And so for those patients, we actually put them on a ketogenic diet where we strictly limit how much glucose they have in their diets in order to make them more acidic on purpose to keep them from having seizures. That's another case where we therapeutically would put them into this kind of state. Okay. Next we have our phospholipids, and so these are really important for our cell membranes, and so these are going to be basically your fatty acids. Again, those are going to be polar or nonpolar? Nonpolar, right? So lipids typically going to be nonpolar, right? But we actually put them with this polar head, so a phosphate, right? So phosphate is basically just an ion. So by combining these two together, you get this phospholipid. Okay, phospholipids are really important because of the fact they have a polar head and a nonpolar tail. They allow us to have these cell membranes that can form. So you notice here they form this double layer typically, where we're going to have the phosphate groups either on the outside. So say for instance, like this is a cell membrane. Here would be the extracellular space. Here would be the intracellular space. They kind of form up nicely in order to form this kind of impermeable barrier for the most part to prevent things from going through, particularly like water and other things that are larger molecules. So it'll be really important when we talk about our cell membranes probably next lecture. But it's also really important because it can act as a surfactant. You guys know what a surfactant is? Helps to reduce surface tension for things. So, for instance, you have your lungs. The reason why they stick to the cavity is because they have a surfactant that helps to hold them there instead of collapsing, right? So that surface tension being lowered by the surfactant helps hold everything together. Otherwise, your lungs will just squeeze up and then you can't breathe, right? So that's when you see like a pneumothorax or something like that. You can have interruptions there. We see it most often in the pediatric side when you have a premature baby being born. So say like one that was born at like say 26 or 28 weeks gestation, they actually come out with their lungs underdeveloped, right? So again, babies, where do they get their, fetuses, where do they get their oxygen from? From mom, right? They don't have to use their lungs, right? So if they come out too early, they haven't cooked enough, they end up having their lungs being underdeveloped, and so we actually have to give them surfactant to allow their lungs to help to fill normally, right? So that's one thing we actually do for them to help supplement that. And you can see what the chemical structure actually looks like here. Just have this phosphate group. Again, you can have multiple of these kind of forming this nice lipid bilayer. So if I say a bilayer, that's what I'm meaning there. It's just the two non-polar ends are going to be kind of meeting up together, where the polar ends are going to be facing the water side, basically. Okay, next for chemical composition, a few minutes. We have steroids, and so steroids are going to be really primarily used for what, do you think? Yeah, so a lot of hormone function, right? So I heard someone say like anti-inflammatory. That's absolutely right as well. It just depends on the type of hormone that you're going to be talking about. But steroids are kind of a wide category of substances. I'm sure when people think steroids like in the gym, think about like androgenic steroids, think about anabolic steroids. But certainly we can think about anti-inflammatories. We can think about sex hormones like estrogens, progestins, testosterone, things like that. So lots of different things. Even vitamin D is considered a steroid, right? Mainly because they all contain this similar structure. And they're all coming from cholesterol itself. Cholesterol is typically made in the liver based on the lipids and things you're ingesting through your diet that can help to utilize that to form cholesterol. And then it can be converted into lots of different things. So for instance, you have your sex steroids like progesterone, androstenedione is another one that can be eventually converted. I'll show you some tables later that shows all the different interconversions. You have cortisol, which is a glucocorticoid. It's an anti-inflammatory. Talk much more about those in detail when we get to the endocrine section. But so we'll see a lot of steroids that get used. We use steroids a ton in the pharmacology world. So for instance, like, if you have an inflammatory condition, we give you anti-inflammatory steroids to help to tamp that down. What do you think is another common steroid that we use to treat patients? It's like female patients. Birth control, yeah, it's another very common one we use. Again, we're using steroids, the sex steroids, particularly estrogen and progesterone, in order to help manipulate the female's ovulatory cycle to hopefully suppress it and prevent pregnancy, right? And do lots of other things with it too, but that's just one example. So definitely a wide-ranging categories. Okay, I think I'm going to go ahead and cut it there. If you guys have any questions before I let you go, a few extra minutes. Nothing at all. Okay, so I'm going to post this up on YouTube. I'll have a link to the video underneath the actual lecture itself. We'll continue on with this, I believe, on Thursday. It's also a link to the YouTube playlist on the actual website itself, so you can click on that and actually get to all the videos if you wanted to. Any other housekeeping stuff. If not, I will see you guys on Thursday. Thanks so much.